Welcome to Adherence 2020. I am glad that you have been able to join us today for the session Left Behind, Recognizing and Acknowledging the Faces of the 10-10-10 in 2020. My name is Erika Castellanos. I'm a transgender woman living with HIV, and I am delighted to be your host for this session. We are all deeply aware of the 1990 goals. 90% of people knowing their status are diagnosed. Of those, 90% are on treatment, and of those on treatment, 90% are virally suppressed. In some countries, great strides have been made towards the goals, and a handful have achieved them. But the vast majority of the world is still facing challenges to reach the goals. Strategies, programs, interventions, and multiple tools have been developed to reach the 1990 goals. But what about the other 10-10-10? What about those 10% who are not part of the target to know their status? The 10% who are not targeted to receive treatment, and the 10% not virally suppressed. Who are the people that belong in those 10%? And why are we allowing this? To answer these questions, we have a panel of experts who will help us understand who are the 10-10-10 and why they are being left behind. But very importantly, we will hear how to close the gap. With this, I proceed to introduce you to our amazing panel today. We have Ms. Dina Riquet, who is a well-respected activist and strategist for persons living with HIV, sex worker rights, LGBTIQ, and specifically the Black and people of color community. Dina is recognized as a leader and champion within the Netherlands and France, as well as in Brussels, where she has been the first PPOC trans activist in European commissions and focal point networks of the Council of Europe as representation of TGU in her previous role as strategic director. Next to being a lawyer and currently a PhD student in Int'l, she is also a trained nurse and director of the first trans-led health clinic in the Netherlands. Our second panelist will be Joyce Ouma. Joyce is a young woman living openly with HIV from Kenya. She is passionate about the meaningful involvement of adolescents and young people in all decision-making spaces. She represents adolescents and young people at the Kenyan CCM and is also a youth member of the community's delegation to the board of the Global Fund. She is an AVAC 2020 fellow from Kenya, with her project being on advocating for effective sexual reproductive health and HIV integration for adolescent girls and young women in Kenya. She is also an observer of the Youth Council to the Executive Director of the Global Fund. With us, we also have Justin Smith. Justin is the director of the Campaign to End AIDS at Positive Impact Health Centers, where he works with community partners to develop and implement strategies to bring about an end to the HIV epidemic in Metro Atlanta. He currently serves as a member of the Presidential Advisory Council on HIV/AIDS. For the last 20 years, Justin has worked in a variety of capacities in LGBTQ health and HIV research, focusing primarily on improving our understanding of the social determinants of HIV among marginalized communities in the United States, particularly Black, gay, and bisexual men. Justin holds an MS in Behavioral Social and Health Education Sciences from Emory University, and a Master's in Public Health in Health Behavior from the University of North Carolina at Chapel Hill. Arianna Lint, who is our other panelist, is the executive director of Arianna Center, a community-based organization that provides advocacy, education and training, case management, and linkage of care for transgender men and women in South Florida area. She is also part of the National Board of Positively Trans, the Prevention Access Campaign U = U, Trans Latina Coalition, and the Well Project. She is a refugee from Lima, Peru, and law graduate of University San Martin de Porres. Arianna has spoken at dozens of trans and HIV-related conferences, and she worked like consulting for the White House National HIV/AIDS Strategy in the past administration, CDC. She is also an outspoken advocate for trans women living with HIV and the needs of expanding PrEP and mental health access to the transgender community. Dina, we'll go with you first. In many countries, in many developing countries particularly, key populations have the notion that Europe is a safe haven for key populations. Speaking of those left behind, please share with us about the realities of migrants and sex workers in Europe, how and why they're being left behind, and what can be done to close the gap.
Thank you, and good evening, and thanks for having me. That's a very nice and good question. I think in Europe overall, for trans people, they've never been really included in the HIV programs, such like trans specific. So I mean, I think in general it was very much like the MSM and as well women at a certain point, but trans people, they've always felt into the sort of gap between either being in the MSM cohort and also in the treatment routing, and that's been like the consequence of not having a lot of data actually on trans people living with HIV. And I think we as activists, we've been now pushing very much forward so that it's included, so that when people enter clinics, it's tagged as a trans person and they will get the treatment. And where we're striving through it too is that actually we try to combine it then with hormone therapy. That's the vision that we want, but that we are currently having with Int'l medics, and it's somewhere going in a certain way. I think the gap, and especially in Europe, we deal with a lot of migrants, and migrants are not always only coming from, let's say, areas such as South America or Africa, but also people who come from the former colonies. And those are sometimes in Asia, sometimes in the Caribbean. And those people also come to Europe and have less access in a way, or it's more difficult for them to go to hospitals and get the medical care. ILGA Europe has made a very good report on it actually, and the name of it is let me check. It is LGBTI Equality and Human Rights in Europe and Central Asia, and it's to be found at the ILGA Europe website. And then I thought it's also good to mention for people who are interested in Europe, the FRA, the Federal Agency of the European Commission, has issued an LGBT survey in 2012, and there is also one about 2020, so you have a bit of ideas about what happened in Europe, and then you can see per country also what is happening on the health area. And then we saw that people have been, and that was in 2012, 22% of trans people surveyed by the European Fundamental Rights Agency felt that they had been discriminated against by health care personnel. So you already see a bit the fringe, the difficulties that you might find in having the access, because discrimination is not only on the way of how people are perceived, but let's say the whole pathologization of trans people has been really a part of that idea about people coming to the clinic. There is a mental illness, and we first will look at that. And that has always been with the psychiatric diagnosis, of course. That has been really a long time part of the diagnostic idea about trans people, on what kind of wards they were coming in. It doesn't matter, actually. I've been working as a nurse on several wards, and it was always something which has predominantly been under the doctors and the nurses. Whenever someone came in with a trans identity, they find it difficult to deal with, because they thought it was more psychiatry and instead of something else. And if you come for something totally different, for example, for HIV, still that idea is around it, and people, and especially trans people, feel that kind of difficulties. So entering to clinics and coming into the prevention groups as well, it's really important in Europe that we are focusing it from the community-led perspective, and that's what we're trying to do now together with the physicians, to find the closure of the gap and the figures that we want to reach, of course, the 1990 goals. That is where we really see that the people within the trans community who are the most marginalized, those are people also who are, for example, criminalized by law. People who do sex work in many countries are criminalized because of third party laws or the Nordic model that we have here in Europe. It means that you cannot access very easily the hospital if you have something with for example, STD or HIV. There's already a layer of difficulty there. And we see it in the community. So whenever someone comes in and really wants to do the testing, we can do it in our own community. And we see that with, like, say, the diagnosis that we have and the cooperation with the hospitals, we have this sort of warm handover to the medics, and then you see that the therapeutic relation between a doctor and the community member is more stable, because we first have been within that intervention trying to give some understanding about the situation of that person. Also, for example, the pronouns are very important, that the doctor knows what is needed to say to the person, how does that person wants to be seen, and all those kinds of things really help in the contact within the doctors. So we try to sort of like help the medical staff into how to proceed trans people, and also how to understand how our community works, because the community is also very complex in a way. We are now dealing with more, let's say, non-binary people as well. We are dealing with trans identities that are more fluid. So we really see that we have to, as well within the community, understand very well who are we working for. I think in the trans community in Europe, we're sort of like finding our ways. But one thing which is also interesting is that in the trans community in Europe, overall, HIV has never been or not been a very easy topic to speak on. It has been always there, but it was never it's been so sort of like stigmatized, but also there was a layer of let's say, there were other issues to fight for first here, and it was more about legal gender recognition and things around the depathologization, I think. So HIV has never been really picked up by the community itself, and I think now we are trying to get into, because we really want to fight as well for the PrEP, for the trans community, for example, that it's really important for young trans people who are yes, let's say now in a situation where they can use PrEP and prevent getting HIV infected. So it's something that we as a community sort of like try to dive into, but we do try to do it together with the medical field, because we see that we have to sort of like get them to understand how complex and diverse our own community is.
Thank you very much, Dina. You mentioned some very good points around the importance of addressing mental health and community-led interventions. Can you tell us briefly how community-led interventions have made a difference to reach those that are most marginalized in society?
Yeah. So, for example, in Paris and in Amsterdam, and as well, I think we are seeing it in London, where the trans community organized their own clinics, where you can talk about hormones, but also about HIV and STDs, where people can come in and drop in, can talk freely about, for example, as well, issues around drug use, all this, and sex work, and things that are normally not very easy to speak on. So there is this community feeling, where we can give people the basic needs, so the basic needs on hormones, for example, and as well the security of cooperation with the larger hospitals. I think that is where we see that the people who for example, are homeless, who have no income, who are found and lost, for example, young kids on the streets, where they find their new sort of like the first possibilities to channel and to speak and to learn from other trans people. So that is what we try to do, and we see that that those vulnerable, most precarious groups are there, and especially in the COVID period now, we see that people who have full stop, no food, no income, also have no medical, well, no money for medical stuff. So people are coming for at those centers for STD checkups, but also for hormones, talks about medication, especially HIV medication. And this is actually what we see, because in Europe, many with the lockdowns, many borders have been closed, and sometimes people were locked up in a country where they actually couldn't go to their own doctor or hospital, so they didn't have enough medication. And then we, with the community, we helped out. We could, for example, communicate with Paris office and find out the recipes for that person who came from Paris, and then it was brought to Amsterdam, and then we could go to the hospital and get the medication done for 3 months at least. So this is something that I think where we see the most precarious at this moment are migrants, sex workers, the Roma people. I think that's also very important to notion, Roma trans people and travelers. And the refugees. I mean, it's something that we in Europe also get quite some refugees from Africa and from Arabic countries, Syria, for example. And I think it's sometimes really hard. Yeah, it's really moving to see how people have this idea, we come to Europe because we can be free and we will not be killed here. But then people have the issues about getting their, for example, HIV and hormones. And they never had that, for example, in Syria. So then you see, then sometimes you're thinking like, we're in the Western European Union, and people come here for their safety, but we cannot deliver them directly the help that they should need, the academic help. And that's where we all the time try to find the liaisons, the connections with the doctors, to show where are the gaps and where are the cracks and where people are the people falling in.
Thank you very much, Dina. That's amazing work that you have been doing, and the organizations you work with. So, Justin, we are aware of the huge HIV prevalence disparity between the general population and men who have sex with men. Black, gay, and bisexual men face even more challenges: exclusion, stigma, and discrimination, and the list can go on. Can you share about what you have learned in your work about the challenges, the disparities, and what is needed to address the negative impact HIV has in Black, gay, and bisexual men?
Thank you for that question, and thank you for inviting me to be a part of this really powerful panel. I'm really just excited to be here with such an esteemed group of folks that are doing incredible work around the world. So just to do a little bit of level setting, I think one of the things that I think is so important when we think about understanding disparities between gay and bisexual men and the general population when it comes to HIV, and also within the community of gay and bisexual men, we look at different races of men, at least within the United States. Something that's really important to know that is been established over the last several years with research that has come out, done by Greg Millett and others, that we've established that these disparities that we find in HIV prevalence and AIDS deaths among Black, gay, and bisexual men and Latinx gay and bisexual men compared to white men is not due to differences in either risk behavior or drug using behavior, or these things that folks might assume given the kind of racist notions around the pathologization of Black sexuality that say that Black folks are more promiscuous or doing other things. But we know that from the research that does not bear out. And what we find is that these disparities are really due to what we all know as the social determinants of health. So thinking about things such as health insurance access. So speaking from the United States perspective, that is a large issue. So it was sobering to hear some of our colleagues in Europe talk about some of the struggles that folks there have with accessing medication. Since here in the US, we sort of look at Western Europe with a little bit of envy, given the many countries in Europe have universal healthcare systems, which is not a feature of the US. So it's sobering to hear that even within these systems that offer universal coverage, there are still these access disparities. But we know that in the US, part of what explains at least part of that disparity is differential access to health insurance. Given that we know that when folks are able to tap into medical care, they're able to access HIV medication and reach viral suppression, that we know has profound implications, not just for the person who is living with HIV, but also for their partners and for their community in terms of reducing the overall risk of transmission within the community. So, so that is at least part of what explains that disparity. Other things that we know are important are these more structural determinants. So in the US, we have sort of a patchwork of state laws that criminalize HIV. And that is something that many people are working very hard to address, to kind of modernize these statutes to such that they reflect the best understanding of our scientific advances. But that continues to be a challenge. And we know that that's also going to play a role into some of these disparities that we see, given that these criminalization laws are going to have a more disproportionate impact on Black and Latinx folks compared to their white counterparts. Something else that we know is kind of behind these disparities that we see is the fact that much of our HIV service infrastructure just deals with HIV, right? And we're not kind of addressing folks in their wholeness and sort of speaking about their needs as a person beyond their HIV-related care needs. And some of the most successful programs that we see in the United States that deal with the needs of Black, gay, and bisexual men, other same-gender loving men, are programs that, you know, will address HIV and have services related to that, but also really take these men as whole persons and develop services and programs that speak to those needs. So I'm thinking about a group such as Thrive SS in my home city of Atlanta, Georgia, which has a online network of Black gay men, not just in Atlanta, but across the country, and can provide more holistic support to folks. And that's really important because it isn't just that they're providing HIV services, they're providing services that speak to the wholeness of people. So that includes, you know, kind of building social connections and social capital, providing, you know, portals to access for mental health, which we know is so vital. So it's thinking about how do we make sure that while folks might be there to have their needs met in terms of what they need for their HIV care, there's a whole host of other things that folks are going to need. So making sure that our programs attend to that. I think one of the other challenges that we have in the US is that so much of our messaging around HIV prevention is rooted in this deficit model, where we go and we assume that communities are not sources of strength, power, and possibility, but are rather sites of disease and pathology. And we don't leverage the myriad strengths that exist within our communities. And I think that that is a huge missed opportunity. And that goes into what I think are some of the solutions that we can build upon. So one of the things that I think is so important is to make sure that organizations, not just community-led organizations, but also within our federal government institutions, within the institutions that are our philanthropic partners, that we have more meaningful involvement of people living with HIV in leadership roles from the communities that are most impacted. So what would it mean if we had institutions like CDC or NIH or all these other types of large bodies that derive a lot of what happens in the United States with respect to HIV, what would it mean if we had more folks from our communities that were in leadership roles in these agencies? So that's something that I think is a path forward. And also thinking about it at the community level. We have so many organizations that work on serving our communities, but too few of the folks that are leading those organizations actually look like the people who are being served. And that is something that we must change. I think, one of the other things that we have to do is think about how do we address these more structural stigmas. So thinking about the patchwork of laws and policies that we know have a negative impact on not just LGBT folks, but Black folks, and sort of, not saying that those are mutually exclusive categories, but just thinking about right now in the US, we're having a massive reckoning around racial justice. And we can't ignore how that also impacts queer folks and gay and bisexual men, because we're also part of those communities. And so if we are going to address HIV, we also necessarily need to attend to these sort of broader structural concerns. Thinking about, criminalization and police brutality, thinking about kind of access to healthcare, thinking about access to stable housing. These are all things that we know are undergirding some of these disparities. And while these are things that are long well known to those of us that have worked in the HIV space for a long time, I think the rest of the United States is really waking up to these disparities due to the COVID-19 pandemic, which has really laid bare a lot of these structural disparities that, again, those of us that have worked in HIV are no strangers to. But I think we have to kind of have that more holistic lens in order to really address the disparities. I think, we wouldn't be remiss if we don't talk about the ways in which homophobia, racism, transphobia, all these things are also playing a role in the disparities that we see, and how those are not just sort of personally mediated, but how these are reflected in the structures and systems that that shape the access to care. So we have to make sure that we are addressing that as well. And so, I think that's where I would start with thinking about kind of what the problem is, what are some of the things we can do about it, and what's a path forward.
Thank you very much, Justin. You shared with us a wealth of knowledge there, particularly about those misconceptions about disparities that some people might have on regards to the social determinants and other risk factors in the community. It was good to hear from you about the need for more engagement of communities, but not only to sit around the table in decision making, but to be in leadership roles. That is crucial. And I think this is something that we must really advocate for. You talk about, the need to address a person as a whole in a holistic manner. In many parts of the world, the community more and more is asking for that. When we are talking, in the era of the SDGs, and there's a lot of conversations about universal health coverage and vertical versus horizontal health systems, how do you think we can manage to get there to the point where we have holistic healthcare systems that have a people-centered approach?
Well, I think that part of it is around this broader recognition that that is what is needed. And I think that's the first part. I think one of the things that I feel hopeful about, and sometimes I don't feel hopeful about a lot of things, but I think that there is a broad recognition that the systems that we have in place, particularly here in the US, and so I'll speak from that perspective, that they don't work for us, right? And so I think that, the more folks are demanding that these things change, including the way that our healthcare system is structured, and the louder those demands are. And I think that there are so many people that have really laid out what a vision of a better system would look like. I think it's basically trying to figure out how do we empower folks that have those visions to be in the leadership roles to drive the change that we know is necessary. So, and so I think that what this moment of reckoning has made possible around a whole host of things, right? I think that there are, policy demands that are being made right now that 5 months ago would have seemed impossible. And so I think that what's happened is this groundswell of activism has really changed the conversation about what we could think of as being possible. And so I think that translates over into the healthcare space, where we know that, having a system that does not center the needs of people in their wholeness is not the way to move forward. And so figuring out what is the policy infrastructure that would support that. And again, that's going to be a heavy lift in the United States. But I think that there are folks that have been thinking about this. We can look to models in other countries, and we've seen demonstrations of what that looks like in our own country. So the challenge is thinking about what type of policy environment do we need to create here in the United States to just give birth to these ideas in a way that is the way that we all want. So that's what I'll say for that.
Thank you very much, Justin, for those remarks and a great input and a lot of knowledge and things to think about. So we're gonna move on to Arianna. And Arianna, you're doing amazing work in Florida, particularly with the trans Latina community. And transgender people always come up in the conversations when we mention those left behind. But do we all know who we are really talking about? How are trans persons being left behind, and what are you doing to address this issue in your region?
Yes. Okay. Hello, and thank you, Erika, for the question. And also, I'm located in the south of United States, in South Florida, and also we give services to Puerto Rico, and that's why I think personally, I think as a human being, nobody want to be behind, right? And I think for many years, this conversation of the transgender is and left behind in the conversation. I think right now, I truly believe in the empower of the transgender and the real and truly meaningful involvement of the transgender community around to the world. As a transgender, trans Latina openly living with HIV, as a CEO of one of the organizations who gives direct services to the most vulnerable community, as a transgender, trans Latinx services, as a transgender who they are survivor and doing survivor sex, and different other communities and groups who they are really some real vulnerable. Even though in United States we are is one of the potentials in the world, right? But also, I am the only one of the transgender openly living with HIV who right now suing the HHS, this administration, to for discriminatory to discriminatory access to healthcare for a transgender individuals. Because as a trans Latina living with HIV, I know you can have being detectable, I know you can have a medical care, but I'm privileged. Many of my sisters who they are really be outside on the street and dealing day by day just for housing. Thanks God right now, one of the CDC directors programs and projects put housing as a healthcare issue and healthcare cover too, right? So some grants right now, they can cover housing for as a prevention, because I think it's important. If in this administration, and also we are in election time, so it's no, I don't think right now, no community in United States is behind, even though transgender community, because in United States, just for one vote or two votes, decide who is the president. So I think we have to evaluate, and we have to have the power and realize the power what we have. Personally, as a board member of the Positively Trans, I'm working with one of my best mentors, Cecilia Chan. We identify the power of the transgender community in United States is figure out data, because we don't have data. Even this is a potential a country, we don't have a data for transgender community. Just CDC last year or this year released a few data, what we are not accurate, really, because sometimes they don't working when the most grassroots organization. But also in 2016 and 2019, we have the data, we create data for transgender women of color openly living in HIV in Fort Lauderdale area and in Miami-Dade area. So we have in our language and in the conversation, when we are somebody think we are behind, we coming with tools to empower the transgender community and educate others about our transgender and transgender issues. I think right now the topic of the immigration is really critical, specific in the South. 2 or 3 trans Latinas living with HIV was died in the hands of the ICE detention center and correctional facilities, right? So I think we have to really thinking about it. But the most important and the most proud I am is because not just myself, but around the world is many other transgender activists and persons who did really working with the community. We doing the change, and we acknowledge the power to never be behind again. That's why I'm open my organization in South Florida in 2015. And for me was empowered because I am a transgender long-time survivor living with HIV. As a transgender, many people, they give me the option or they don't see me in positions like director or CEO. So I think this is like a true empower to the whole community and to my own community while we serve. We provide HIV testing and linkage and care and prevention. We provide emergency safe housing for transgender who they release the jail and they are HIV positive, or they living with HIV and they release the jail. Is very important. They have that window when they don't have a housing. We cover the housing emergency. We do a name change and gender marking, and also for trans Latinas, we provide services, a program for encourage to the GED classes and English as a second language over here locally. We pay for that. We do virtual programming, advocacy, leadership training, because I truly believe in the leadership of the transgender community. And I think as a personal histories and the data, and with the empower of the transgender community, we can not ever be behind in the conversation.
Thank you very much, Arianna, for your enthusiasm, your power that you transmit with your words. So you shared something about data and how some institutions that are producing data, sometimes it can be poor quality because they don't go to where the grassroots, to where the community are. So how is your organization doing to reach those places, to reach the community where they are, to produce high quality data that is community driven and led?
We are really think we cannot be behind, or we cannot go forward if we don't working as a community and in community, right? I think it's very important of the academic sector, because we don't have too much access to education. That's why one of my biggest fears or projects for me to give to my community is provide tools to educate English, GED classes, to empower and leadership those communities. But I think data is very important. After we provide data in Florida, As example, we partner with the University of Puerto Rico, with the School of the Master in Public Health, with the Doctor of Carlos Rodriguez, and also his doctor in one of universities in Washington D.C. The Green with someone organization, university in Washington D.C. And we together made the first transgender need assessment for people living in Puerto Rico who they identify as a transgender. University of Puerto Rico and Dr. Carlos Rodriguez just asked me for 120 answers to make that data perfect. In Florida, we find 140, 150, but in Puerto Rico, we make historical. We create 320 answers who we provide to the University of Puerto Rico, and we're going to release soon, before this year, 2020, the data for Puerto Rico. And this is very historical, not just for the transgender community, but for the studies, for the research people, when they looking for transgender research, and they don't find it so difficult to find 20, 25. When you meet and when you partner with grassroots agency, when the true leader who they can have the bridge with those vulnerable community, we can have those numbers, we can have these changes. So that's why I think working together is important, and we really be excited to continue working and make it a change for the whole community.
Thank you very much, Arianna, and congratulations on the data that is being produced, and we'll keep an eye open to be able to access it pretty soon. I now want to go with Joyce, our youth activist. And Joyce, can you tell us what are the challenges when reaching young people? What are we doing wrong, and what can be done differently?
Thank you very much, Erika, for that question. Young people aged 15 to 24 are actually a very huge population. We actually form about 18% of the world population. And what's interesting about this population is that we have various subpopulations within this particular group. Among us, we have adolescent boys and young men, we have adolescent girls and young women, we have young key populations, we have young people living with disabilities, we have young people living with HIV, we have young people who are transgendered, and the list goes on and on and on. Now, when reaching young people, currently programmers have been using several assumptions, for instance, that have been actually the cause of the several challenges that people are currently experiencing when it comes to reaching us as young people. The first assumption is that the assumption that young people are a blanket population, and therefore one intervention will fit us all. And the second intervention is that the same interventions that work for the general population will actually work for us. So these two interventions, or rather these two assumptions, have made it rather very difficult for us to be reached as young people. When it comes to the challenges that young people are experiencing, or rather the challenges that are being faced when reaching young people, in terms of access to information, we find that the several barriers that exist for us as young people. One is the use of the traditional channels of information dissemination. Programmers are not trying to be innovative. They're still continuing using the difficult, or rather the initial channels of information distribution that was used before. The other issue that is really a barrier to us is the complexity of the language that is being used. Programmers are not using the language that we need, or the language that we can understand, or the language that we can decipher. So this makes it very difficult, and half the time the targeted audience is usually not understanding what is expected of them. Another thing is single-channeled information. Like I have mentioned, when the different subpopulations among young people, it is very, very important to note that one information channel cannot work for all of us. we need different interventions, or we need different communication channels, be it through social media, be it through radio or print media, because we have different needs and we even have different personality traits. The other challenges that are being faced when reaching we are young people can be divided into two. We have legal barriers and we have structural barriers. Now, the legal barriers present themselves in form of when it comes to age of consent, and adolescents and below 18 years cannot be able to consent for services, and cannot even be able to assent for specific services. So parental consent is required for an adolescent to get services, for example, in countries like Kenya. The other legal barrier is the criminalization of certain subpopulations within the young people, especially the young key populations. The young key population, especially in certain countries where sex work is not allowed, and where same-sex marriages are not legal, and where the drugs that are being injected are not legal as well. This has posed a very serious barrier for such young people to be able to access services, and therefore that's why they cannot be accessed in regard. The other issue is on structural barriers, which can also be referred to as lack of youth-friendly services. Now, youth-friendly services is a term that has been thrown around severally and has been interpreted differently by donors and everybody else, depending on, one, the size of their pockets, or two, the specific area or region that this is supposed to be implemented. But young people have a different definition on what youth-friendly services are. But currently, what is going on? We have um, lack we lack these services. We lack these facilities that offer these services. And why am I saying this? We have facilities that are having inflexible operating hours. We have facilities that have staff members or healthcare workers who have very, very poor attitudes. We have facilities that have high cost of services, or even any cost of services when it comes to young people is a lot for us. And we have certain facilities that are not easily accessible to us as young people. In regards to what needs to be done, or rather what needs to be done differently, or what needs to change, I have maybe 3 or 4 things to say. The first one is that we need to keep up with the trends. We need to work with what is going on in the current world. We need to evolve with the situation as it keeps evolving. Like currently we have social media platforms, or we have online platforms and applications where young people and the general population, if they like, can be able to access information. They can be able to access referrals and linkages to services. We have even in situations where certain applications are being used to book slots at the facility, or rather to book appointments at facility levels, and saving on the time that one has to stay at the facility. And alongside many other innovations that actually have come to light, especially during this time of COVID-19, where mobility is not really an advantage that we have. The other thing that needs to be done is to meet young people at their own terms. Like we need not to start negotiating on some of these issues. We need to understand that no one intervention can take care of all the needs of the 18% of the young people, and not one intervention can take care of all of us in all our diversity. The other thing I'd like to say is we need to use young people friendly language. Complex language might sound programmatic and everything, but they usually lose out on the target audience. And that is where we have been lost from when it comes to access to information. So when the language is targeting young people, it needs to be to be diverse, and it needs to reach us in our own language, and in a language that we can easily decipher. And finally, we need to provide youth-friendly health services. And like I said, these are our non-negotiables as young people, for us to be able to easily access services, for us to be able to easily walk into a facility, or to even feel incentivized enough to walk into a facility. These services are like flexible operating hours, trained healthcare providers with very good attitudes or healthy attitudes. Free services, like I have said before, that minimal costs or affordability is not a luxury that we can afford to have as young people, because most of us do not have jobs. So free services need to be created, and we need to have integrated services where I can walk into a facility and get all my issues catered for at once without necessarily having to be referred or to be linked to a different facility for me to be able to get some of my essential needs, like my sexual reproductive health needs, which are almost going hand in hand with my HIV needs because of the risk behavior that possibly I am putting myself into. And then facilities need to be easily accessible to us, and they need to be providing privacy and enough confidentiality. Thank you.
Thank you very much, Joyce, and thank you to all the panelists. There's so much richness in information that we can go on for hours having these conversations and learning so much. But I'm going to ask the final question to all the panelists. What I would like to hear from everybody is, we always hear the term um, populations hard to reach or people hard to reach. This is often used in the HIV response to talk about certain communities. It is used by donors, by states, by civil society. So, what are your reactions to this term, and what do you have to say about it? Let's start with Justin.
So thank you. And I really, really have a strong antipathy towards that term. And I'll say why. I think for me, one of the things that that term does is it places the blame on the communities that we're talking about. So it says that there's something wrong, you're hard to reach. There's something that's wrong with the community that you need to fix as a community member. I think a more helpful way to kind of have this conversation is to think about what's making the systems and the services and the programs that we have to offer hard to access. Because what that does is it places the onus on those of us that are designed and charged and are accountable to communities to think about better ways of organizing the way that we work and we serve the community. So I think it also gives us something to do, right? I think that if we go out and we assume that, communities are forever hard to reach and fixed, which, A, it's not really true. And B, it doesn't really give us a lot of agency in dealing with that. I think that we have to think about what are we doing to make the systems hard to access? And I think that gives us work to do. So I would offer sort of a reframing of the conversation to say that, rather than say that communities are hard to access, to think about systems as being hard to access. We know that for the communities that we term hard to reach, they're also not hard to reach for people who are in those communities, right? So, reaching transgender women might be hard for, cis white gay men, but it's not going to be hard for other trans Latina women, right? And so I think that's also part of what we have to name in that conversation.
Thank you very much, Justin. Arianna, any comments from your part?
Well, I think, and as I told you, I think I truly believe in the leadership of the transgender community and the independent of the transgender community. They can working and make the change. I think we are not the problem; we are the solution, and truly believe in the education. HIV is not the problem. The problem is the people they are not educated about HIV. As a spokesperson for the You Equal You campaign, I think it's important to introduce the correct language about You Equal You, and also put new language for topics in the field, as a sex workers, as a transgender, who they are trans Latinas, in the undocumented people. I think it's all the disparities we have to working together and get, and I truly believe, really I hope and I think working together is the best what we can have, and I think we can make the change, and working together. So thank you so much.
Thank you very much, Arianna. And we move ahead with Dina.
I think the structures, as far as what I can see from here, is that the structures are built on inequality, especially looking at how it is organized in Europe, and as well how that has colonized large parts of the world. Structures that have no intersectionality in it, and especially me as an academic, I see it from the inside. Of course, I've been working quite a long time in that academic field and in the universities, and then you really see that I am the one who need to learn others about my background, and that's really strange. While the people that I'm surrounded by have been organizing the countries where I came from, like, so it's very political in a way. Um, and of course, those structures are not built for people like me to be in there. So of course, I'm invisibilized in those structures. So it is to us now to learn others about intersectionality and what it is to be part of oppression, or part of us, of not being totally part of the whole picture, and how to build a society where everybody is included. So I think for me, the diversity and the inclusion of especially of people of color and those who are marginalized because of their identities, they need to be seen as full and need to be included. And we actually sort of like need to fight ourselves into the structures and change it from within. So I think that's sort of like my dedication to it, is to try to move that around into the new era. And I really copy and echo it from Jason. What I've heard is that now it is the time to do it, because it's like we are in this new sort of energy where we really see that injustice has been structural in this world, and it's now time to change it, because injustice, and especially intersectional justice, needs to be there. And that's actually what I think is my solution, is that we all are activists as well, need to change that, because our voices are heard, and our knowledge is as well part of, we've been educated within that system. So I mean, I also took my knowledge from it, and now it's time for me to change the narrative.
Thank you very much, Dina. And lastly, we will hear from Joyce about populations left behind.
Honestly, I do not agree that certain populations are hard to reach. I do not, for instance, agree that young people are hard to reach. I mean, we are everywhere. We form 18% of the world population. I just feel that the situation is as it is because the states, the donors, and even members of the civil society, we do not want to leave our comfort zones to go and meet these particular populations. And in my case, we do not want to go and meet the young people in places where they are found. We do not want to meet them at their own terms, because at the end of the day, they are the only ones who know what works for them. Thank you.
Thank you very much. What an amazing panel we have here today. Justin, Joyce, Dina, Arianna, thank you for your words, for your observations and recommendations. And, the public out there, donors, civil society, states, there's no such thing as populations left behind. You're just doing it wrong. Let us do it as community. Thank you very much. Continue enjoying Adherence 2020.